Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will embark on a special format, coffee and conversation with 7 clinicians joining us in 4 breakout rooms. We have Dr. Scalia in breakout 1, Dr. Marava Kosiks and Dr. El Sharqui in room 2, Dr. Grotman and Dr. Lashman in room 3, and Dr. Ganetsky and Dr. Vernon in room 4. Each room will have our very own ambassadors moderating discussion around the themes of Mito 101 and patient rights and responsibilities. Please do not enter the rooms until we instruct you to do so. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors, so we ask that you join us in thanking the Edith Trees Charitable Trust and UCB for their ongoing support. Okay, let's get started. You can now go ahead and proceed to your desired breakout room, and if you need any help, just let Jessica know and she can help you out. Enjoy. All right, well, welcome to the Adults Patients Breakout Room 1, Mito 101, Things I Wish I Knew Years Ago. We have with us Dr. Fernando Scalia with Baylor College of Medicine from Houston, Texas. And our ambassadors are Joy Krumdiak, Alpa Patel, Sylvia Washington, and Sharon Shaw. I'm Kara Strittmatter. I'm the Director of Education and Support Services, and I will be here just kind of monitoring the chat, answer any questions you may have for technical issues. So what we would like people to do is to raise their hand to ask questions. Our ambassadors are going to kick off asking a question to Dr. Scalia to kind of get that conversation going. But if you do have a question, we do ask that you go ahead and raise your hand. And that way we'll call on you and you can ask your questions.
Tara, who do you want to respond to the people raising their hands? So will you do that?
You guys can. Actually, it's fine for one of you to say, hey, I see you, because more eyes on the screen helping me, the better. Right. Because I think I'm going to probably get texts from other rooms. Okay, I didn't plan this out well enough. I need to duplicate myself a little bit, I guess. So yes, if you guys could help with that, that would be greatly appreciated.
Will do.
So let's go ahead and get started. Sylvia, do you want to go ahead and get us started on our question?
Yes. And we had, some of the ambassadors had talked about this before people joined. So I'm going to ask a question to Dr. Scaglia, and then I'm just going to pass it to the next ambassador. And then we'll get those questions going and we'll leave it to the rest of the audience if that's okay with everyone. So this is my question. Dr. Scaglia, I just shared with you that unlike a lot of people that I'm encountering in this space of mitochondrial disease, I'm late to this community. And one of the things that's being asked of individuals like myself in the year 2023 is that we do genetic testing. But there's 2 types of genetic testing, and one, the exome testing and versus whole genome sequencing. And one of the questions that is on your list should have been, I have genetic test results, but what is best? What is the most definitive diagnosis? Is it from whole genome sequencing or is it from exome sequencing? And the reason why I put that question out there is because I'm an epidemiologist. I do peer review, and the peer review literature that I read was that whole genome sequencing is a better shot at getting at the genes. And I've done both whole exome, the exome sequencing and the whole genome sequencing. And there is just a huge world of differences in terms of the amount of information on genes. So what is best, exome sequencing or whole genome sequencing?
Well, thank you. Thank you so much, Sylvia, for that question. That's wonderful. So, well, definitely, I would wholeheartedly agree. Genome sequencing is better than exome sequencing. And obviously, the reason would be that, so with exome sequencing, we are only looking at a very small percentage of the whole genome, only what we would call the coding regions of a gene. Let's say in plain English, that would be the regions of a gene that eventually get translated into a protein. But if we look at the exome, we are only going to be looking at genetic letter changes or absent genetic information, let's say like small deletions or insertions in areas of the gene that will be translated or eventually made into a protein or will direct a protein to be manufactured. However, there are other areas that are called like non-coding. They are called introns in the genetic jargon. And you can miss that. I mean, definitely that will be missed with exome sequencing. And, that can affect the editing of a gene, how the message is edited. In addition, there are other genetic letter changes in what we call regulatory areas. Gene is actually subject to like a very specific, very sophisticated regulation by sequences of genetic letters that are like upstream or downstream. And if exome sequencing is done, then that is missed as well. In addition, I would also say that, I guess I don't want to give names of laboratories or get into conflicts, but, like way back, few years back, when somebody, let's say a clinician, would request exome sequencing, at the same time, the mitochondrial genome would be looked at. But then, for many labs, those two tests were separate. So in many cases, when a clinician, geneticist, neurologist, orders exome sequencing, that laboratory is not actually looking at the mitochondrial genome or will not report anything. But if a genome or whole genome sequencing is requested, then that will also look at the mitochondrial genome, and any genetic letter change or deletions, when there are like gaps of genetic information, then will be reported. So definitely genome sequencing. Obviously, the issue will be, in many cases, insurance approval, right? As a clinician, if I go to an outpatient clinic, it will be, much easier to get approval for exome sequencing than genome sequencing. And I think I can think about, like if we do that for, let's say, children at Texas Children's Hospital, sometimes this is done as an inpatient because then we have to talk to the hospital. And in many cases, the hospital is actually absorbing the cost of the test because obviously there's a difference in the expense, in the cost of the test. Yeah.
Thank you so much. I just want to do just want to make a comment and a follow-up question. So, because I'm new to this space, my exome sequencing, I won't mention the company, said that I had no mitochondrial disease. I paid for my own whole genome sequencing by 2 companies. I was stunned this weekend. They found over 10 nuclear mitochondrial genes. And also they found 2 CPT2 variants that were considered pathogenic or likely pathogenic. And so if I had been a patient and just accepted the exome sequencing, even though I had all the symptoms, it would have been very devastating to my health. So that's why I wanted to ask that question. And thank you so much for that answer. I'm going to go to the next ambassador. Sharon, would you like to ask a question?
Yes, thank you so much. Let's see, I'm just, I think this question is a really good one because when I was first diagnosed, it was almost 24 years ago. Every mitochondrial patient that I know, we call it our Mito cocktail. And I know as science has advanced, more types of mitochondrial diseases have been identified. What would be the must-haves in the Mito cocktail? I know CoQ10, I've been on that for 24 years. I also learned that to get the best bioavailability from the CoQ10, you also have to include B vitamin and alpha lipoic because they are the transporters. At least that's what I was told. So to get the best bioavailability from the CoQ, you've also got to take the B and the alpha lipoic. But what is your thought now in 2023 about if you have mitochondrial disease, this should be in your Mito cocktail?
Thank you so much. Thank you, Sharon, for that question. So, following some of the recommendations or guidelines that actually I think that were published from us. I mean, many of us were participating in tonight's session as clinicians from the Mitochondrial Medicine Society that were published in 2017. We and this is what I do. I mean, but I think that many of us do. So I have initially like a minimalist approach, and then I increased that gradually. So definitely, I would start with ubiquinol, and I will mention this. So I will start with like coenzyme Q10, yes, which is an antioxidant, and I would use ubiquinol, which is a reduced form of coenzyme Q10, because it has like better bioavailability. And then I would usually tell patients, let's say adults, or if not parents of a child, but let's like just focus to the adult population. Let's give it a try. Let's be on this for like 4 or 6 months, and then the next time we meet, tell me how you're doing, and then we can start adding more. So yes, the initial, I think the basic. If I'm seeing an adult with mitochondrial myopathy, and by that I mean like muscle disease, I would say like the basic ones that I would try would be coenzyme Q10. I I add lipoic acid to that combination and creatine. And that's actually based on probably I would say like the first study or even trial using these 3 medications together was done by Mark Tarnopolsky, a neurologist and exercise physiologist in Canada. And, it did show some improvement in certain areas. And, I would usually tell folks, well, if I'm going to add creatine, I want to make sure that the kidney function is fine within normal limits. But yeah, I would do that incrementally. So, but those would be like the 3 main ones. Then, people ask me about levocarnitine, and I would say, well, look, let's check. Let's run your carnitine levels. If the carnitine levels are low, then we will add levocarnitine, but not necessarily so at the very beginning, and certainly not without checking levels. Then if people ask me about like vitamins, I would say, well, we can start with like a B vitamin. We can start with like a B vitamin complex. And then there are like different conditions where we may not necessarily use the same approach. I have patients with Leber hereditary optic neuropathy, and then they will ask, what do you think about idebenone? So my response will be, well, look, there has been a trial, a clinical trial for idebenone. Idebenone is like an antioxidant. It's like chemically similar to coenzyme Q10, but it crosses the barrier between the blood and the brain in an easier way than coenzyme Q10. And it's been approved in Europe. It's been approved in the European Union, by the European Union regulatory agency, in Israel, in Iceland, in Norway, not in the US. But I said, well, look, we can try idebenone and see, if you notice any difference. Idebenone rather than coenzyme Q10. Just to give another example, there are other conditions, for example, where we may try folinic acid. So we have actually done that for Kearns-Sayre syndrome, and we have actually done that in like Golgi related disorder, because folinic acid has been shown to be low in the spinal fluid in some of these patients. So yes, we can say that coenzyme Q10 and maybe the addition of like lipoic acid and creatine and a B vitamin complex could be like the core. And then there are other conditions that may require other compounds. I think I can think of now is, we do work in that area for Miller syndrome. Traditionally, we have used, many of us have used arginine or L-arginine, in particular if that particular person has a history of metabolic strokes. We just concluded a clinical trial for L-citrulline, so that's why I've been very hesitant in telling people, well, use this dose, because the trial was a phase 1 or has been a phase 1, and it's a dose-finding trial, but we will hopefully have data that will be analyzed and obviously share with the community soon. Yeah.
So Joy, can you ask the next question, please? Unmute, please. Joy?
I actually have a question, Joy, real quick.
Okay.
Rhoda Fish, you had a question. What is the cocktail used for adult MELAS patients?
I see. So, well, yes. So I think so. So let's say this: if the adult person who has MELAS has, by definition, metabolic strokes, we will still use ubiquinol. We will still use lipoic acid, and we will still use creatine if the renal function is normal. Because I have seen patients with MELAS syndrome with abnormal kidney function. Okay. Now, in addition, then we will be using L-arginine, which is an amino acid. Yeah. If the person had previously a metabolic stroke. Sometimes I think the terminology can be very confusing because, MELAS can be a big umbrella, a big tent for even like hearing loss and diabetes. And in that case, I don't think that we have enough data to suggest that, just by using L-arginine in that particular case, we may accomplish something if a person has not presented with strokes. Yeah.
Joy?
Yes. I want to back up on the cocktail. I had heard that the CLA, or conjugated linoleic acid, was something to add. What is your thought?
Thank you for that question, Joy. No, we have not, and I do not. I do not use it. You will see. We have guidelines for our Mitochondrial Medicine Society, but of course, since in many of these cases, obviously, these are compounds that are like purchased, over the counter. In some cases, we do work, I think, locally with a pharmacy in Houston, and I write a script for coenzyme Q10 and for ubiquinol, and we have been able to get that covered by insurance, but that's really very place dependent, pharmacy dependent. So, we try to be careful with what we prescribe, but you will see that there are different options and different providers. But no, that particular compound, we have not. The other compound, I think, that we have been using in the pediatric population and in the adults is niacin. And the rationale for that is that an investigator from Finland, who actually will be participating in the 2024 UMDF meeting in Cleveland, Anu Suomalainen, she has published her research on adults with mitochondrial myopathy. So these are adults who have like muscle disease, muscle weakness, exercise intolerance. And she found that niacin in muscle and in blood of those patients she studied was low. And by providing niacin, those the levels actually were increased, and then they evaluated certain muscle functions in that particular study. So we have actually added niacin now, with a word of caution. So as a side effect, niacin can actually cause bloating, or in some cases, it may also cause flushing, bad facial flushing. So some patients, some adults, some of our folks who actually come to our clinic had to stop that.
Okay, Monica, would you like to ask your question now? Your hand is raised. Monica Smith? Yeah, there you go.
Thank you.
You're welcome.
So if you have mitochondrial myopathy, but you don't necessarily have a mito doctor and you don't know what type you have, and they start you on that cocktail. I know they started me on the cocktail, and they started me on 10,000 milligrams of creatine a day, which killed my kidneys. And you don't really have a mito doctor. How do you know like what to be taking, what's safe? Like for those people who don't have a mito doctor, how do you know what to do?
Thank you. Well, thank you for asking that question, and I'm sorry you went through that. I think it would be very important to be seen, even if a person is not a mitochondrial specialist. I think that typically you will find two types of doctors who will be, better able to handle and treat patients with adults with mitochondrial disease. One would be either a neurologist. It's true that not necessarily all adult neurologists are very familiar with mitochondrial disease, or a geneticist. So, and I think that, in many cases, those folks would be at an academic center. It would be like a, university, affiliated hospital. I understand that, not everybody lives close to those centers, but I think that, it would be, let's say, safer to get advice from either a geneticist or a neurologist who's, aware of that. There's also, I should also say, because some, I know that it was actually one of the questions listed there previously, UNDF and organizations like Mito Action, they usually have, like per state, like cities or centers where, recently diagnosed folks with mitochondrial disease can go to. So I think that would be the safer approach. Yeah.
Thank you.
Anyone else want to raise their hand with like a question for Dr. Scaglia?
I do.
Michael Goldstein.
Yeah, hi. Thank you.
Michael. Yeah.
I'm a very newly diagnosed Mito patient, and the condition is also not very familiar to most of my medical team. So I wanted to ask, what is the standard of care for patients who are fully dependent on TPN and IV fluids and nutrition?
So, well, I mean, I think, there's not, I guess I can think of this. I can think of, for example, patients with a condition called Mengi, and in that particular case, we have seen some of those patients, and they were TPN. They were like TPN dependent, and I think that it's also very important that a mitochondrial team would have a dietitian, a registered dietitian, because in many cases, physicians are not aware of like certain dietary needs, not only for patients with mitochondrial disease, but patients in general. So I think maybe I can think about like my own experience. I attend a metabolic clinic where we see children and adults, not with mitochondrial disease, but with metabolic disease. We work with registered dietitians because it's very important to calculate, okay, what are the protein requirements for this particular person? What are the energy requirements? And they are different depending on the age. Now, if I move that to our mitochondrial clinics, yes, we do work with registered dietitians. I would say that the majority of our patients are not necessarily TPN dependent, but regardless, I think it's very important to make sure that there are no deficiencies of, let's say, essential fatty acids, that there's not like a protein deficiency. So I think it's very important that a physician would actually work with registered dietitians. Now, regarding IV fluids, which is something that I haven't answered yet, which was the second part of your question, we do know that, for example, our children with mitochondrial disease, but also our adults, they don't do very well with, let's say, with heat in the summer, or they may have also issues with infections. And, if they need to be fluid resuscitated, we have specific indications about like the fluids that actually need to be used. For example, D5, so which is like 5% dextrose concentration or sugar concentration, as opposed to like 10% dextrose. So because we don't want to see the lactic acid bumping up and increasing in blood, or or indications for not using lactated drinker. And what we do, which is actually, I think, that linked to another question, is that we do prepare for each child and for each adult who comes to our clinics an emergency letter. So in that case, then whenever that person goes to an emergency center, an emergency department in a hospital, they will have our instructions about fluid management. We also provide another letter if that person is going to have surgery, let's say like an elective procedure, and then there are like orders not only for sedation but for fluids, obviously, because we can't just say, well, that person will be under and will not get fluids for certain period of time. Obviously, that's not good either. So,
Dr. Scaglia, I like to.
This is I was going to say, this is a really good segue, because another important topic for all patients is how in the world do we best manage our portfolio? I have seen patients walk in with, it looks like War and Peace, and it overwhelms the doctor. And so, in 24 years of me navigating this horrid disease, and a team of 15 different doctors, and none of them really talk to each other. How best, what I knew then, I wish I knew then what I know now in terms of organization, but as a doctor, what is really important to you? What is it? Is it a summary? And then if the doctor wants, they can go deeper into the rest of the profile. How best to manage our profile when it is so complicated?
Then can we have Alpa ask her question, Sharon, because she had her hand.
I'm so sorry.
All right, that's okay. I would just like to get all the ambassadors in to ask a question. That's okay, and come back to you. Go ahead, Alpa.
Of course.
Go ahead, Alpa. You're muted, Alpa. We can't hear you.
I think she's reading, but somehow
I can't hear her.
I can hear, I think.
So we'll go back to Sharon and just until Alpa gets her video. Her audio.
Sure, that's actually that's a very important question. I think that well, first, I think that I was talking about. I think it's crucial that this person would have an emergency letter, and in the emergency letter, we do. Our emergency letter is certainly not an encyclopedia. It's probably at most like a 2-page letter that they will carry. So we will send that via my chart. We use that message. We use that messaging system for our pediatric patients and also for our adult patients, because we have like these two separate clinics, pediatric and adult. But we also print that. We also share that because it's important to have a hard copy. And I think that in the first paragraph, I think it's very important to say, this is so and so. I'm very familiar with this patient. This patient has this, this condition, these are the main features. So it doesn't have to be a paper, a manuscript that we are writing, obviously, for an emergency room physician, but at least an abbreviated form of the description of the syndrome. And then we would say, well, but when this person comes, she or he could have this symptom. So please, place an IV line, an intravenous line, get these labs drawn, start this type of IV fluids, avoid this other type of IV fluids or lactated drinker. There are, if the person is prone to, let's say, I'm giving these examples, prone to seizures, we would say, well, please do not give valproic acid, because we know that that's a toxic to the mitochondrial toxin. And then we will say, please contact us. So our names are there, and our, call numbers, operators, and, and numbers for like, weekend, after hours. So, because we do have like an on-call service. Now, going back, I think, to another part of your question, because it was not just like emergency, I think it's communication. I think it's very important. I will say this. I started seeing initially children with mitochondrial disease than adults with mitochondrial disease. And I can see the difference in it's like two different cultures trying to talk to each other, very different mindset. I find that there's a more integrated approach in the pediatric world than in the adult world. But I think that in the adult world, I try to at least reach out or make contact with a family physician or with an internist and say, look, I'm available. Please call me. Sometimes it takes me to call that person. I just don't wait for a phone call, because in some cases they get very busy and it doesn't happen. But I think we have to make an effort to really generate a connection with that primary care physician, right? Yeah.
We have two more questions. One is from Joseph. So Joseph, can you ask your question, Teresa? And then Ed, you had your hand up at some point in time. So let's do Joseph. Your question. Where are you, Joseph?
Hi. I was diagnosed with Lee syndrome and Mealis earlier this year in July. And my question concerns.
Okay, we can't hear you.
Okay. Can you hear me? I have the
yeah,
I am unmuted. Okay. How or what to the doctor, what is your experience with how mitochondrial disease can affect the eyes? Because I'm having an experience where more often than not, my eyes feel tired. My vision is good, the focus and everything, but it seems like the muscles and the nerves are strained. But giving me like a difficulty reading. Like when I'm reading a paragraph, read to the end of the line, it's difficult to get to the beginning of the next line.
Thank you. Thank you, Joseph. So yes, definitely mitochondrial disease can affect the sensory organs, and in particularly the eye. And we see that in children and we see that in adults. I think that's why as part, let's say if a person is just diagnosed with mitochondrial disease, but even if she or he is already carries this diagnosis, it's very important to be seen by an eye doctor regularly. I mean, there can be, you already mentioned that you feel tired. So obviously the muscles that actually elevate the eyelids can get very tired. And, and in many, for many folks, they will have what we call ptosis, like droopy eyelids, right? And they need to have at some point maybe some type of surgery. So we do refer. I think it's very important to be seen by an eye doctor. And when I mention an eye doctor, sometimes there's always this confusion about, I already went to one, and that person prescribed glasses. Well, that's an optometrist, right? That's a common sometimes a mistake. It should be so yes, I mean, an eye doctor actually will be able to look at, your eyelids. In some cases, some folks, because the extraocular muscles are weak, so they cannot really move very well their eyes sideways, up or down. But in addition, it's very important that that eye doctor would also be a specialist in the retina. So it's important to have a dilated eye exam and then look at the back of your eyes. Why? There are some conditions where the pigment that is found in the retina can be affected. And so that particular person may have difficulty walking at night, or will bump into objects, and that's not good, right? Then that person is at risk for falling, which we try to prevent. And then there are other issues. We see that, I think, mostly in children, but then we can see that in maybe folks who actually are no longer pediatric, but optic atrophy. But I mean, typically we see that in children, right? There could be problems with the optic nerve, so issues with the eyes, and we see that in, let's say, the first mitochondrial syndrome that was actually reported in the United States by Doug Wallace back in the 1988. That was actually the report, was Leber hereditary optic neuropathy. Those are folks who have been doing very well. And then maybe at the end of their teens, early 20s, then they may lose vision in one eye. And then 3 months later, they may lose vision on the other eye, right? So that's, I think it's key. It's key to have, that's kind of the basic evaluation for mitochondrial disease, not only the heart and other organ systems, but the sensory systems, the vision and the hearing.
Yeah. Ed, do you have a question? Because Ed, you've been waiting for a while. Ed Marks. Ed?
Yeah, I'm here.
Thank you.
Doctor, I was very interested in your comments about finding a Mito doctor. The problem is that there are many parts of the country that are so desperately underserved that it's very difficult to find anyone who is able to provide care. I was diagnosed about 16 or 17 years ago. They did not do the only then definitive test, which was a muscle biopsy, because the doctor said it wouldn't make any difference. The cocktail was the only thing that he could try. He could vary it. But I understand that sequencing is now the diagnostic tool of choice. My question is, how do I go about getting that sequencing? Do I need a prescription?
Well, I mean, I think it's key to be. I don't know what part of the country you live, but I think.
Florida.
I beg your pardon?
Florida, Tampa Bay.
Tampa Bay. Okay, so I think it would be key. And I'm thinking about the name of the specialist that actually may live in your area, but I think it's important to be seen by a geneticist, and I know that there are geneticists in Tampa affiliated with the university, either a clinical geneticist, a medical geneticist, or a genetic counselor, because I think that an evaluation really has to be done first, because then hopefully that will be the person who would provide counseling for you. And I would say that now more than ever, genetic confirmation is very important because there are more clinical trials that are being launched. And, we started back in 2013 with that, and I was part of that EPI 743 trial that was for children with Lee syndrome. But now there are also trials for adults, and all of these trials require genetic confirmation, molecular confirmation.
Teresa, you had a question? Teresa?
Well, it was back when Doctor was first speaking about, you're mentioning different conditions, different protocols, and I think you said something about something for neuropathy that you use for people.
I used the word myopathy, which essentially means like muscle disease, rather than neuropathy. And we trial niacin, and if tolerated, we will continue with that.
Alpa,
I thought you were talking about neuropathy.
Okay.
You did mention LHON, so that might be where the word neuropathy came in.
Oh, yes, that's correct. Thank you so much. Thank you, Devin. Yes, I mentioned that because actually I mentioned LHON, or labor hereditary optic neuropathy. Yes, yeah. And there are, in that particular case, that's when we talked about, Ibivenon, and usually, those are the, in those cases, as part of the counseling, we usually tell, families, or tell the adult patient, that, there are certain things that can make things worse. So, for example, smoking is bad for health anyhow, but smoking can even be worse for labor hereditary optic neuropathy. And I think it has been seen epidemiologically that those folks are actually at a higher risk for losing their vision, actually, and followed by alcohol intake, even occasional alcohol intake, because it generates like oxidative stress, if you want to call, like free radicals, and that can be detrimental for the vision. Yeah.
Alpa, can you ask your question now? Alpa?
Oh, can you hear me at all?
Yes, thank you. Oh my gosh, thank you.
I'm so sorry. I was trying to navigate. Most of my questions have been answered. This has been a very good discussion, but I did have some follow-up questions. I know we've been talking about therapeutics and supportive care. I myself have had cardiac issues with my mitochondrial disease and that actually. And I've had a pacemaker put in for several years ago actually. But so my question is, how well are you coordinating with the other branches of medicine and coordinate? I know you mentioned nutrition and neurologists, which I know pulmonologists and that actually, but I did not mention and nephrologists, but I think the cardiologists really need to be in the game plan in there actually, honestly, because it does affect the AV node in the cardiac cycle.
Just let me add to your point, Alpa, because that's how I got introduced to my mitochondrial dysfunction, was because of a heart issue. That's how they found mine too. So, yeah, thank you for that question.
Sure, I think we do refer to many studies. I think many services. But what we initially do, for example, is if let's say that I see or we see an adult who has recently been diagnosed with mitochondrial disease, we will order ahead of time an electrocardiogram and an echocardiogram. And then, obviously, depending on the results, we will not hesitate in referring to a cardiologist. So, yes, we do work in close proximity with, I would say, cardiologists as well as neurologists. My profession, I'm a geneticist, but I do work closely with neurologists and cardiologists for the adult mitochondrial medicine clinic. And then, of course, there are cases where We have patients with MILAs who also have like kidney issues. So, then we have to interact with nephrologists, right? And then there are, as we initially learned from the pediatric population, then immunology, because, there are, folks with mitochondrial disease could have like, decreased immune defenses. So there are many, many subspecialties.
Yeah, I agree.
Any other questions from the group? Karen, go ahead. Karen, unmute. Unmute, Karen. Unmute.
Okay, I got it.
Okay.
All right. I'd like to go back to the finding a doctor question for a minute. I was unfortunate enough to have lost my doctor. He died, and he was a fantastic doctor. And when he died, since he had died, I've been unable to find a doctor in the Minneapolis-St. Paul area. I was rejected by Mayo Clinic. I was rejected by Gillette Lifetime Clinic, where I used to go. And the university sent me to a doctor who kind of knew Mito, not really. And my medical group also sent me to a neurologist who said he knew Mito, but did not. And so I'm at the point now where, because it's been 5-6 years since I've really seen someone who can care for me, my primary ends up being my main doctor. How do I connect my self to a doctor that would be outside of my geographic area, that would actually be a reasonable distance for me to travel? Because I don't see it happening in Minnesota unless somebody can help me find a doctor, which the referral systems, like through United Mitochondrial Foundation, they have not been able to find me anyone, and neither has Mito Action. So I'm looking for, if you know anyone in Minnesota.
Well, actually, I do. There is a geneticist, and in fact, she's not a pediatric geneticist. She's board certified in internal medicine, and the reason I know her well is because she trained with us at Mito, and she was one of our biochemical genetic fellows. And I want to say that it was either in 2019 or 2020. She moved to Minneapolis, and I think that she's affiliated with the University of Minnesota, and her name is Angeli.
So I really want to thank everyone. I don't know how everyone felt about your rooms. We really want to hear your feedback. But I know there was a lot of questions, and I know we couldn't get to everything, but it seemed like a very engaged group in group number 1. So I don't know how everyone else did in your breakout rooms. I do want to let you know that we will have a resource document that our ambassadors worked really hard on to pull together some resources that we will share with everyone along with the recordings. So I just wanted you to know that will be coming. It may take us a little while to get the recordings for each breakout room together, but we will be posting those on our Mito U. I really want to thank the doctors and the clinicians for being on tonight. I hope you found it interesting and engaging and not too overwhelming for this late at night. And also the ambassadors for helping us. This was actually this coffee and conversation breakout rooms was the idea of our ambassadors and Margaret Moore. And I think it was a really great opportunity to do something different for us, the Mito Doc. Maybe we'll do this once a year. We'll see how we've learned a lot. There was a lot of things we learned along the way here that we will remember and put into play. But I would really appreciate any feedback. Make sure you email us, and let us know if you have suggestions. And that's to the clinicians as well. If you feel like there'd be something that would work better for you, please let us know how you felt about the webcast tonight. So with that being said, I just want to thank you all, and we look forward to seeing you all again next month. I believe it is December. I could share the screen, and it will be a wrap up with our 2023 with our Mito Doc. But yes, we will have 4 or 5 Mito docs on in December, and we look forward to seeing you all back then. Thank you and have a good